Good morning, all of you. Hope you're all doing good. So today we'll be discussing about the topic radiographic interpretation of dental caries. So dental caries is a microbial disease of the calcified tissues of the teeth that is characterized by demineralization of the inorganic portion and destruction of the organic substance of the tooth. This destruction is brought about by the acid-producing bacteria in the mouth. These bacteria break down the carbohydrates to form the acid that demineralizes tooth structure, and this leads to caries. So how do we diagnose caries? The diagnosis of caries is actually made through a combination of clinical examination and radiographs. So first thing, we have to clean and dry the teeth and clinically examine it, which we can do by gentle probing on all the surfaces of the tooth, the proximal, occlusal, buccal, lingual. We can also diagnose caries by the method known as transillumination. So in transillumination, it involves directing a bright light through the tooth surface. And if there is caries present in the tooth, it will be seen as dark areas. Following all these, we can go in for radiographs. So radiographs in some cases gives us better picture of a carious lesion. So how do we see caries on a radiograph? So in radiographs, usually carious lesion appear as dark or radiolucent. So this appears radiolucent because caries actually causes tooth to demineralize. So when there is demineralization happening on the tooth, it allows greater passage of X-rays. And when X-ray passes, greater X-ray passes through an area, that area appears dark or radiolucent. But there are a lot of limitations that the radiograph have in order to diagnose dental caries. So these limitations are, firstly, only 40% of demineralization has happened in a tooth will be able to detect the caries on a radiograph. Otherwise, the caries won't be visible on a radiograph. Then the actual depth of the carious lesion will be deeper than what we see on a radiograph. Thirdly, radiograph is a two-dimensional image. So we are seeing two-dimensional image of a three-dimensional tooth structure. So there will be a lot of superimpositions, magnifications, distortions. All these can obscure the diagnostic ability of a radiograph. And then finally, we are not able to distinguish if whether the lesion is active or if it is arrested, because both these lesions will be seen as radiolucent on a radiograph. So these lesions, the treatment aspect is entirely different. So we have to clinically look for these lesions and diagnose these lesions rather than taking the help of a radiograph. So let's see what are the different radiographs that we can employ to diagnose caries. The most commonly used radiograph is the intraoral periapical radiograph, or the IOPAR, followed by bite-wing radiographs. Actually, bite-wing radiographs help us more to diagnose interproximal caries. Then if there are a lot of tooth involved with caries, we can go for an OPG or a panoramic radiograph. Or we can, nowadays, we can use digital sensors to take radiographs. All these methods are used to diagnose caries using radiographs. Let's see how radiographs, different caries appear on radiographs. Firstly, the occlusal caries. In case of incipient occlusal caries, usually these caries begins in pits and fissures. So they start at the side of the fissure, and then they tend to penetrate perpendicularly into the dentino-enamel junction. Radiographs are not very effective for the detection of occlusal carious lesions because when it is only confined to the enamel is very radio-opaque. So any small radiolucency in that area will not be seen on the radiograph. So until the lesion has not reached the dentine, we will not be able to see the image on a radiograph. Next is moderate occlusal caries. So in case of moderate occlusal caries, usually we see moderate occlusal caries as a thin radiolucent zone which has a broad base and that is present in the dentine. We will not be seeing any changes in the enamel. So this is a picture showing how we see a moderate occlusal caries. So we see it as a radiolucent zone with a broad base at the dentino-enamel junction, and the lesion is in the dentine. And in the radiograph, we'll be seeing enamel with no apparent changes. In case of severe occlusal caries, this can be observed both clinically and radiographically. Previously, the incipient and the moderate one sometimes will not be able to see it clinically also. Okay. So in case of severe occlusal caries, we can see this both clinically as well as radiographically. So here, usually the underlying dentine is carious and it is not able to support the enamel. So when there is masticatory forces, the whole thing collapses. So radiographically, severe occlusal caries usually appear as large radiolucency as seen in the image on the slide. Okay, so that was occlusal caries. Next, in case of proximal caries, in case of incipient proximal caries, usually proximal caries develops very slowly and it takes 3 to 4 years to become clinically apparent. And when it is clinically apparent, it is seen as chalky white opaque region. Due to this, the incipient lesions will not be visible on a radiograph usually. But if at all it is visible, it will be seen as a radiolucent notch on the outer surface of the tooth. That is incipient proximal caries. Now, in case of moderate proximal caries, this involves more than the outer half of the enamel. And because of this, it might be appearing as a triangle with its broad base at the surface of the tooth. That is seen in the image given in the slide. This is a triangle with a broad base at the surface of the tooth. Or it may be appearing as a diffuse radiolucent image, or it can appear as combination of these two. That is a triangle with a broad base at the outer surface, or as a radiolucent, diffuse radiolucent image. In case of advanced proximal caries, this carious lesions has actually invaded the dentino-enamel junction and it is spreading. There is demineralization process at the dentino-enamel junction, which then subsequently extends into the dentine. So on a radiograph, we can see radiolucent penetrations throughout the enamel. Okay, that is seen in the image here given in the slide. There is radiolucency penetrating the whole enamel, extending into the dentine. So here in this image, we can see how the errors in the horizontal angulation will obscure the diagnostic ability of a radiograph. So in the first one, we can see we have given ideal horizontal X-ray beam angulation, and we can see the carious lesion is actually in the confined to the enamel on the proximal surface. And when we check the radiograph, we'll see the shadow of the carious lesion confined to the enamel. In the second image, when the horizontal angulation is incorrect, we'll actually see the carious lesion confined to the enamel as extending into the dentine. That is because the X-ray beam firstly passes through the carious lesion on the enamel, then to the dentine, and then it falls on the radiograph. So we'll see a shadow of the carious lesion appearing to extend into the dentine. So in this way, the exact picture of the carious lesion is not seen on the radiograph. Here, when there is a large proximal lesion, the first one is showing a large proximal lesion that is not involving the pulp. So even if we give a correct angulation, taking a radiograph, there will be superimposition of this large lesion over the pulp, which is shown in the image. And when that happens, the resultant image what we get will give us an idea that the lesion is extending onto the pulp. In the second image here, even though the lesion is appearing or the lesion is actually involving the pulp, we'll get an image on the radiograph where we'll see it is not involving the part. So these are some drawbacks of the radiograph in diagnosing proximal caries. Next is facial, buccal, and lingual caries. So these caries usually occurs in enamel pits and fissures, and when these are small, they appear as radiolucencies, round radiolucencies, and as the lesions enlarge or extend into more area, they become elliptical or semilunar in shape. So the facial, buccal, and lingual caries, clinical examination is more important because since the radiograph is a two-dimensional image, there is superimposition. So most of the times we won't be able to actually identify where the lesion is, and the exact depth of the lesion is also not identifiable from a radiograph. So in radiographs, as I said, it appears as smaller radiolucent areas surrounded by dense area of normal tooth structure. Sometimes this can be mistaken as occlusal caries. So if the radiolucency is superimposing on the dentino-enamel junction, we can mistake it as an occlusal caries. So it is very difficult to differentiate a buccal lingual caries on a radiograph. So how we can differentiate it? Usually the occlusal caries is more extensive than a buccal and lingual caries, and the outline of the occlusal caries will not be well defined, whereas the outline of the buccal or the lingual caries will be well defined. It will be round, or it will be elliptical or semilunar in shape usually. So this is a radiograph image showing buccal or lingual caries, but since it is overlapping onto the dentino-enamel junction, it is difficult to distinguish it from the occlusal caries. But here we can see it has a well-defined outline, and there is a dense normal tooth structure surrounding it. So this is one way of distinguishing buccal or lingual caries from an occlusal caries. So this is an diagram that is showing the difficulty in distinguishing from a buccal and lingual lesion, because when the X-ray beam passes and falls onto the radiograph, both will be seen as same. The similar problem happens when the lesion is shallow and deep, because the depth is not identifiable on a two-dimensional image. So we are not actually able to identify the depth of the lesion. So that was buccal and facial lingual caries. Now let's move on to root caries. Root caries are usually seen in older people because of gingivalization bone loss. So it involves the cementum and dentine, does not involve the enamel. So usually in radiograph, it appears like a saucer-shaped or notched radiolucency. So here you can see on the molar distally on the root surface, there is a saucer-shaped radiolucency. That is root caries. Next is recurrent caries or secondary caries. It occurs adjacent to restorations, and this can result from poor marginal adaptation of a restoration, which leads to marginal leakage, leading on to initiation of caries process beneath the restoration. It can also begin due to inadequate extension of the restoration, incomplete excavation of the previous caries before restoration, and also can be initiated due to a fracture restoration, where again there is leakage happening. So on a radiograph, these secondary caries are seen as radiolucent areas adjacent to the restoration. Some restorative materials, radiolucent restorative materials, can also resemble recurrent caries, like composites or silicates, acrylics, can resemble dental caries. So we can distinguish a radiolucent restorative material from a secondary caries because the radiolucent restorative material will have a well-defined and smooth outline, because it is we are filling it in a prepared cavity, so the outline will be well-defined and smooth. Whereas in case of caries, the outline won't be that's smooth and well defined. So this picture depicts how the difference in vertical angulation will obscure the diagnostic ability of the image formed on the radiograph. So here there is recurrent caries beneath the restoration. So when we are giving an ideal angulation in the picture in the center, we'll see the caries shadow beneath the restoration, whereas when the angulation is incorrect, the caries will be superimposed over the restorative material, which is usually very radio opaque, and we will not be able to visualize the caries on the radiograph. So that will be misdiagnosed. In this radiograph, we can see how the location of the recurrent caries lesion will obscure the diagnostic ability of the radiograph or the resultant image on the radiograph. So when it is exactly beneath the restoration and we are giving a correct angulation, we'll see the shadow beneath the restoration. But if the restoration, if it is hidden, if the lesion is hidden by the restoration, we will not be able to see the caries shadow on the radiograph. Similarly, if there is a buccal and a lingual lesion and there is a restoration in between, we will not be able to see the shadow of the caries due to the very radio opaque restorative material on the tooth. So these are some of the limitations again of the radiographs in diagnosing caries. Next is rampant caries. So rampant caries is usually seen in children. There will be extensive smooth surface caries involving many teeth. Usually the radiograph demonstrates severe dental caries. So this is an image that is showing extensive involvement of all the tooth surfaces. Usually it is seen in children. Next is radiation caries. It is also a type of rampant caries that is seen in patients who receive radiation therapy of head and neck tumors. So when head and neck tumor radiation happens, the salivary glands come in between the radiation therapy. So what happens is there is decreased production of saliva, leading to xerostomia. So when there is xerostomia, the natural cleansing activity of the saliva doesn't happen in the oral cavity. So because of this, caries process is initiated. So this caries usually begins at the cervical region and it aggressively encircles the tooth, and this causes the entire crown to be loose with only root fragments remaining in the jaws. So they appear as dark radiolucent shadows at the neck of the teeth. So this is the image showing radiation caries at the neck of the tooth. So what are the different differential diagnoses for caries? Radiographic differentials. First one is cervical burnout. Then there is aberration and attrition, which is also seen as radiolucencies on the teeth. Then there is proximal wear. And again, restorative materials, which we have already discussed. So let's see what is cervical burnout. So cervical burnout on intact root surfaces may appear carious as a result of a phenomenon called a cervical burnout. So cervical burnout is actually an apparent radiolucency that is found just below the cemento-enamel junction on the root. This happens due to anatomical variation, like concavity on the posterior teeth, or due to the gap between the enamel and bone covering the root in the anterior region. So due to these anatomical variations, there is differential absorption of X-ray happening in this region, usually the proximal region, and this will mimic as a root caries. So the true root caries lesions may be distinguished from cervical burnout by absence of image of the root edge. So in true caries lesion, the image of the root edge is absent. Then a true caries lesion is usually appears diffuse with rounded inner border. Then clinical evaluation and probing of the root surface actually helps in diagnosing if it is a true caries lesion or if it is a cervical burnout. So this is an image showing cervical burnout. Usually it will be seen on all the teeth proximal surfaces. This is actually happening due to a differential absorption in this region of X-ray beam due to the anatomical variation, usually due to the curvatures on the posterior teeth, etc. So you can identify the cervical burnout or true caries lesion by clinical evaluation or by thoroughly looking onto the radiograph, where you can see that in true caries lesion, the edges, the outer surface of the edges will be lost, whereas in cervical burnout will be intact. Then, so that was about radiographic interpretation of dental caries. So even though radiographs helps us in identifying dental caries, usually the first and foremost thing to do is thorough clinical evaluation, followed by radiographic examination. Thank you.